Hey guys, welcome back to my channel, The ENT Resident. Today we'll be doing a discussion on a topic which is our chronic tonsillitis. This is again a very common case that you will see in your OPD and which is your number one indication for performing tonsillectomy. And today we'll be discussing about what is chronic tonsillitis, what is the etiology behind it, what are the three different types of it, how does a patient present to you with? We'll talk a little bit about Brodsky's grading as well. And lastly, we'll end with treatment and complications of chronic tonsillitis. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, what is chronic tonsillitis? As the name itself is suggesting, chronic tonsillitis is a chronic inflammation of the palatine tonsils, which occurs as a result of repeated attacks of acute tonsillitis, or it can also occur because of inadequately resolved acute tonsillitis. So, it is a chronic inflammation where the tonsils are involved, and we know that tonsils are a part of the Waldear's ring, which is a major part of the immunity being provided to the upper aerodigestive tract. And this tonsil, when it gets chronically inflamed, it can be occurring because of two reasons. Either there are repeated attacks of acute tonsillitis occurring, or the acute tonsillitis is not adequately treated. In that case, it leads to chronic tonsillitis. Now, this condition mostly affects children as well as young adults, and it is very rare after the age of 50 years. Now, coming to the cause of chronic tonsillitis, the most common organism, which is the same as that of acute tonsillitis, which is involved over here, is the beta hemolytic streptococcus. This is very important. This is the most common organism involved in the causation of chronic tonsillitis. Now, as I already mentioned, usually it can occur as a complication of acute tonsillitis, like repeated attacks of acute tonsillitis. So, in this case, what we see is on pathology, we see micro abscesses walled off by the fibrous tissue in the lymphoid follicles of the tonsil. So, this is the first etiology. Second is it can also be just a subclinical infection of the tonsils without an acute attack of tonsillitis. And sometimes you'll see the predisposing factor could be a source of infection elsewhere. For example, it can be there is a source of infection in the nose or sinuses or the teeth where the infection has not been treated. So that can act as a predisposing factor in causing chronic tonsillitis. So that's about the etiology. Now, moving on to discussing the three different clinical pathological types of tonsillitis. So we have three types over here. We have chronic follicular tonsillitis, chronic parenchymatous tonsillitis, and chronic fibrotic tonsillitis. Now, as the name will suggest, you'll already be able to guess what is each one of them exactly. So, first we'll talk about chronic follicular tonsillitis. Now, in chronic follicular tonsillitis, this is actually very common in adults, whereas chronic parenchymatous tonsillitis is the one which is more common in children. So, chronic follicular tonsillitis, which is occurring more commonly adults, usually occurs after repeated attacks of acute tonsillitis, which can be even in the form of an upper respiratory tract infection. What happens here is the tonsillar crypts. So, we know the structure of the tonsil, right? So there are primary crypts and there are secondary crypts. So these are the crypts. So these crypts can get actually full infected with fully cheesy material, and these can show up on the surface of the tonsil, which is on the medial surface of the tonsil, as these yellowish spots. That will be what chronic follicular tonsillitis looks like. Now, the pathology here is, as the name already suggests, we'll have chronic inflammation, but we'll also see some fibrosis of the tonsil, and the connective tissue cells in the tonsil will be increased more when compared with the cellular elements of the tonsil. So, this is about chronic follicular tonsillitis. Next is chronic parenchymatous tonsillitis, which is more commonly seen in children in the age group of 4 to 15 years. Now, this usually happens following repeated attacks of acute tonsillitis. What happens here is we know that if you remember the anatomical structure of the tonsil, you can, for more details, you can check out my video on anatomy of tonsil. So the tonsil has lymphoid follicles in it in the tonsillar parenchyma. These lymphoid follicles, after following repeated attacks of acute tonsillitis, they start undergoing hyperplasia, leading to a uniform enlargement of tonsil. So, what you see in here is that the tonsil on both sides gets uniformly enlarged because of this hyperplasia of the lymphoid follicles. Now, sometimes these tonsils can even get so grossly enlarged that they can cause an obstruction to the food as well as air passages. So, it will cause a dysphagia because of blocking the food passage, and because of blocking the air passage, it can even cause a difficulty in breathing in your patient. And these patients, because these are also children, they have also been seen to have concomitant adenoid hypertrophy. So, with this together, the patient will complain of snoring and sleep apnea, and if this goes on for a very prolonged period of time, can even develop pulmonale. Now, the pathology involved in chronic parenchymatous tonsillitis is that there is chronic inflammatory hypertrophy of the lymphoid follicles. And here, the enlargement is mostly due to the increase in cellular elements rather than the connective tissue cells. So that's about the chronic parenchymatous tonsillitis. We'll talk about the Brodsky grading in relation to this when we discuss the clinical features. The third type is the chronic fibrotic tonsillitis. Now, as the name is suggesting, what happens here is the tonsils are fibrotic, they atrophy, they become small in size instead of large. So, parenchymatous tonsillitis is when you see the tonsils have enlarged in size. In chronic fibrotic tonsillitis, the tonsils have atrophied and become smaller in size. There is a history of repeated sore throat attacks, and even though the tonsils have become fibrotic and shrunk in size, the remnants of the tonsillar tissue may still keep getting infected, leading to recurrent attacks. So, these are our three different types of chronic tonsillitis. In comparison to acute tonsillitis, we have discussed in a separate video already that there are four types of acute tonsillitis. You can check my video out to learn more about acute tonsillitis over there. Next, moving on, let's talk about how will the patient present to you with. Now, first we'll talk about the symptoms and then we'll discuss the signs, meaning what do we see when we clinically examine the patient. So, first of all, the most common symptom that we see is sore throat. So, the patient will come to you with a history of recurrent attacks of sore throat, which are basically recurrent attacks of acute tonsillitis episodes. There will be multiple episodes in the past when you take the past history that they have had similar history of upper respiratory tract illness and sore throat and difficulty in swallowing with fever sometimes multiple times in the past. And this recurrent the recurrent the history over here is very important because the number of recurrent episodes will basically decide whether the patient can be taken up for tonsillectomy, whether it is an indication for tonsillectomy or not. In relation to this, the thing that you need to know is something which is known as the Paradise criteria for tonsillectomy. I have a video separately made on this. You can check it out over there. So, after sore throat, the next thing would be a lot of patients complaining of chronic irritation in in the throat, along with cough. And these patients they may also have something known as hawking, which is basically clearing your throat continuously. Hawking is mostly seen if there is an associated adenoid hypertrophy or chronic sinusitis, along with the chronic tonsillitis in the patient. And then patient will also complain of a foul breath and a bad taste in the mouth. And this halitosis, it is caused because of the pus coming out from the tonsillar crypts. Other than this, when the tonsils become very large, markedly enlarged, and it is obstructing your oropharyngeal airway, or path, it starts obstructing both your food as well as air passages, it can lead to snoring and sleep apnea. The patients may complain of choking episodes during the night time when they go to sleep. They can even complain of a change in voice where their speech becomes very thick. And they can even complain of dysphagia, which is difficulty in swallowing because of the size of the tonsil. So these are all the different symptoms that your patient will present to you with, what they'll complain to you with. Next, let's talk about the different signs. Now, coming to signs, when you first examine the oral cavity, you'll see that the patient most of the times can end up having a dry and coated tongue. This happens because if there is a concomitant adenoid hypertrophy as well, we know that in case of adenoid hypertrophy, the patient starts to breathe through the mouth because of the presence of nasal obstruction. So, mouth breathing can also result in a dry and coated tongue. Can you tell me what is the name of the facies that we see in adenoid hypertrophy? That is known as adenoid facies. If you want to know about the features of adenoid facies, this is a very important Viva question, very commonly asked. You can check out my video on adenoid facies, where I discuss each and every feature that you see in the facies and why do you see it. Dry and coated tongue can also be a result of poor food and drinks intake. Next, in case of chronic parenchymatous tonsillitis, which I just mentioned, where the tonsils get uniformly enlarged because of the lymphoid follicle hyperplasia, here you will be seeing that varying grades of tonsillar enlargement. Now, if and when you get a patient of chronic tonsillitis as your long case, when you examine the patient and you write down your clinical findings, very often you are asked about the grade of tonsillar enlargement. Now, the grading that we commonly follow is the Brodsky's grading. According to Brodsky's grading, let's look at the images over here. And this is grade 0, where basically the tonsils are entirely within the tonsillar fossa, right? You're not able to see it. Then grade 1 is when there is a 25%, less than 25% of oropharyngeal width involvement. Grade 2 is when the tonsils are occupying about 50% of the oropharyngeal width. And grade 3 is when the tonsils are taking up about 50 to 75% of the oropharyngeal width. And lastly, grade 4, which is very commonly known as kissing tonsils. That's because both the tonsils are kind of meeting in the midline, like kissing in the midline, because here grade 4 is when the tonsils have occupied more than 75% of the oropharyngeal width. So this is the Brodsky's grading that we follow when we are clinically examining the patient and mentioning the grade of the tonsillar hypertrophy. So that's about chronic parenchymatous tonsillitis. In chronic follicular tonsillitis, instead of a uniform enlargement, we will be seeing yellowish white spots of pus on the medial surface of the tonsil. Whereas for chronic fibrotic tonsil, as we have already discussed, the tonsils are going to be very small and atrophic. And even though they are small and atrophic, when you press on the anterior pillar, you will be able to express frank pus or some cheesy material. So these are the three different chronic tonsillitis and the different findings that you would find in them. Next, let's discuss the cardinal signs of chronic tonsillitis. This is a very, very important question that you will be commonly asked. They'll be asked, what are the three cardinal signs of chronic tonsillitis? Very important Viva question. Out of these three cardinal signs, at least two have to be present for you to be diagnosing it as a case of chronic tonsillitis. So, what are these three cardinal signs? First one is that there has to be the presence of a flushing of the anterior tonsillar pillar. So the anterior pillars, they are hyperemic. Why does that happen? This happens because of the chronic infection going on, there is an increased vasculature present to the anterior pillars, which is why it ends up looking flushed. So our first sign is flushing of anterior pillar. Second is that we should be getting a Irwin Moore sign positive. What does this mean? When you press on the anterior pillar with the help of a tongue depressor, you will be able to express frank pus or cheesy material out. This is known as the tonsillar squeeze test. So here when the cheesy material comes out, this is known as Irwin Moore sign positive. And the third sign is a persistent jugulodigastric lymphadenopathy, meaning the jugulodigastric node is enlarged. And an important feature over here that it is non-tender. That diagnoses a case of chronic tonsillitis. So out of these three signs, at least two have to be present for you to be able to diagnose it as a case of chronic tonsillitis. This is a very, very important Viva question that you should be knowing. So that's about the clinical symptoms and signs. Next, moving on to investigations. This is mostly a very clinical diagnosis where you make the diagnosis based on the history and the clinical examination of the patient. Usually, no specific investigation is necessary. If you're planning the case up for surgery, in that a lot of preoperative investigations would be required before you take the patient up for surgery. Now, I have separate videos on tonsillectomy where I discuss everything related to this, and I also discuss about the different steps of tonsillectomy. You can check it out over there. Next, moving on to treatment. Now, first of all, is a conservative treatment. Whenever there is an acute exacerbation of the tonsillitis, in that case, you will treat the patient exactly like you do in case of acute tonsillitis, which would involve a lot of rest, a lot of fluids to be had, and you'll also start the patient on antibiotics, and you'll also give, in case they are having fever, in that case we'll give an antipyretic like paracetamol, and we'll also tell them to do gargles with antiseptic like betadine or even lukewarm water with salt added in it. So, the acute exacerbations have to be treated exactly like acute tonsillitis. Next, if there is any focus of infection elsewhere, like the nose, sinuses, or the teeth, that has to be treated. And you'll also have to pay attention to the general health of the patient and the diet that they are taking. Next, the mainstay of treatment of chronic tonsillitis is only surgery, and the surgery involved over here is tonsillectomy. And I'm not going to discuss more about tonsillectomy here because I have a whole series of videos where I discuss the indications, the contraindications, the procedure, postoperative care, complications of tonsillectomy. And you can check those videos separately out to learn more about tonsillectomy. But just to remember, the mainstay of treatment over here in case of chronic tonsillitis is tonsillectomy. Lastly, let's discuss what are the different complications of chronic tonsillitis. So, first of all, it can progress to form a peritonsillar abscess, which can further progress to form a parapharyngeal abscess. Then you can even form something known as the intratonsillar abscess. Now, as the name suggests, this is when there is pus accumulation within the substance of the tonsil, right? So, peritonsillar abscess is when the peritonsillar space has an accumulation of pus in it, whereas intratonsillar abscess is the pus within the substance of the tonsil. This happens only once the tonsillar crypt opening gets blocked. These patients will have a lot of local pain and dysphagia. For treatment, you would have to start them on antibiotics and drain out the abscess whenever required. And ultimately, later, after the condition has resolved, you have to do a tonsillectomy later. Next complication is a tonsillolith, which is basically tonsillar calculus. So, calculus formation in the tonsil. This happens when the tonsillar crypt gets blocked, and followed which there is retention of debris which occur. So, here what happens is inorganic salts of calcium and magnesium are deposited, leading to the formation of stone in the substance of the tonsil. And these tonsillolith can over time enlarge in size as more deposits start happening. And they can even cause an ulceration and come out of the tonsil by causing an ulceration. So that is about tonsillolith. Treatment is very simple. You remove the stone or perform a tonsillectomy. Next is tonsillar cyst. What is tonsillar cyst? This will appear as this yellowish swelling over the tonsil. Again, this happens because of the crypt in the tonsil getting blocked. Most of the time, this is very symptomless and can be easily drained out. And lastly, it can cause a complication can be a focus of infection in rheumatic fever, acute glomerulonephritis, eye, and other skin disorders. So that's all about chronic tonsillitis. I hope you've understood this. If you have any doubt regarding this, please note them down in the comment section and I'll get back to you. Thank you.